ahead. You're on.
Hello, everyone. My name is Navid Ghahremani. Today, I'm presenting to you a clinical case presentation on atheroma, a major differential diagnosis for acute neurological emergencies, requiring highly skilled approach to the diagnosis and a robust team effort to resuscitate the subject patient. Together, let's visit the emergency room for a visual exercise.
Year-old male. Onset time at this point is about 45 minutes.
Hi, John. Don't worry. We're going to look after you. Can you smile for me? Have a look at my nose. How many fingers do you see moving? One. Can you point to it?
They're ready for us down in CT.
What I've seen in the years of being an emergency physician is tremendous excitement in the ability to treat stroke, but they're all very time sensitive.
As we can see, the preliminary observations and diagnosis. Atheroma is a very time-sensitive matter. Atheroma has a major probability to threat that threats the CNS livelihood. We can preliminary, so we can tell that atheroma is a major cause for neuronal death. There is 2 million neurons that can be compromised per every minute of ischemia. Now, are every atheroma event possibility for a CNS event or not? That is the question. Let's examine our first clinical case. On August 26 at 8:47 a.m., 62-year-old Caucasian male with chief complaint of vision loss, and a painful blue toes present to the emergency department of DeKalb Medical Center, Atlanta. Mr. Aubrey states that 2 days ago at 8:15 a.m., while working in his garden, he experienced vision changes that was described as mixed blindness and blurriness in the right eye and lasted 1 minute. Normal vision was restored after he washed his face with cold water. No medical intervention or medications were used to help restoring the vision. However, he expresses severe anxiety and fear of total loss of vision at the time. In addition, last night he experiences blue discoloration of his toes concomitant with mild nausea and abdominal pain. While watching TV, laying on his recliner, soaking his feet in warm water did not help, nor taking ibuprofen or Plavix. Feeling of abdominal pain was tolerated and did not become a concern. Now, throughout this case, I'm going to analyze what are the phenomena that can contribute to our understanding as physicians in order to rule in and rule out the diagnosis that goes towards atheroembolism or similar cases, and whether it is involved CNS or it's not involving CNS. So from the past medical history, our patient has peripheral arterial disease and diabetes mellitus type 2 and hypercholesterolemia. Those are significant. From the surgical history, there's coronary angiogram on August 18 at Emory Hospital. Hospitalization history on August 17 was admitted for percutaneous coronary intervention at Emory Hospital. From medications, there's plenty of medications for cardiac conditions. Social history, he lives with his 40-year-old girlfriend, admits to 20 pack of year, smoking tobacco, quit 15 years ago, 12 bottles of Heineken weekly, and a shot of Jägermeister at night. Familial history is significant for familial hypercholesterolemia from the father's side. From review of system, it is very important for us to know that in order to diagnose, we need to see positive pertinent sign and negative pertinent symptoms. Not always we look for positive symptoms. We sometimes diagnose, rule in and rule out conditions based on negative pertinent symptoms. So for now, our patient is anxious with sensation of pain and pressure 4 out of 5 in both feet, denies loss of vision, fever, dizziness, palpitation, chest pain, shortness of breath, and nausea and vomit. Denies ability to walk due to edema and discomfort of both feet. Denies any injury to trauma to the toes of either side. Denies drugs of abuse. Admits to the unprotected sex with other women. On the assessment modality, we can tell that vital signs are slightly elevated. From general appearance, we have a 62-year-old elderly gentleman, reasonably groomed, in clean clothes, awake, alert, anxious, moderate pain and discomfort, wearing open-toe sandals, sitting on a wheelchair, communicating his symptoms with the emergency doctor with no speech difficulties. Now, we need to have appropriate neurological examination for this case. When the patient expressed a partial loss of vision and Bluetooth discolorations, these can be neurological examinations. So a good neuro examination would come to place. We have found that he, on the neurological examination, is oriented ×3. Glasgow Coma scale was 15. And what is pertinent here on the fundoscopy, he has Hollenhorst plaque. I'm going to discuss what Hollenhorst plaque is. Hollenhorst plaques are somewhat specific findings for atheroembolism. Cranial nerves are intact. Upper motor neurons, a strength of 5 out of 5. What is also pertinent, what is a pertinent negative finding here is Babinski. Now, finger to nose within normal limit. And also, we have a speech understanding of the patient. The speech is intact, negative dysprodosia, negative dysarthria, negative aphasia, and negative dysphagia. So these sequelae of negative findings in neurological examination actually help us understand that this may not be a this may not be a not be a CNS involved type of lesion at this point. Now, on physical examination, we have cardio, S1, S2, audible, but what is pertinent finding is S3 gallop, grade 1 out of 5. Murmurs were negative, regular rhythm, regular rate. The rhythm was defective with S3 gallop. Non-descended PMI. Lungs were within normal limits. GI generally was normal. However, he had some abdominal complaint, and it was found that he has palpitation. On palpation, it elicited 3 out of 5 diffuse colicky pain without rebound. There was a constipation as well. HENT was within normal limit. GU was deferred. And on musculoskeletal, we have bilateral pedal edema, 4 out of 5, without sign of skin abrasions or deep cuts. Positive for bilateral rubor of ankle skin, intact, active, and passive range of motion per bilateral ankles and toes. Walking was deferred. Romberg negative. Now, when we have Romberg negative, when we have Glasgow Coma scale of 15, when we have a patient that's sitting and communicating his symptoms, even though he has reported that he had a transient vision loss, it may not necessarily be a atheroembolism to the CNS system. Now we have to further investigate. Now, what would be our clinical hunch and differential diagnosis in this case? Now, we have an embolic condition suited for elderly gentlemen at this time with this presentation would be atheroembolism with acute kidney injury. And amaurosis fugax also fits into the description of vision loss and restoration of vision with no medical intervention. The stroke, abdominal angina, acute mesenteric ischemia, possibly due to the date and time, COVID-19 hypercoagulability state could also fit into this case. However, for something such as fat emboli syndrome, it requires history of bone fracture. He didn't have bone fracture. For infective endocarditis with embolization, it requires fever and fever and a new murmur. On physical examination, he did not have fever and there was no new murmur. Antiphospholipid syndrome, although it's a hypercoagulability state, it usually applies to pregnancy. Certainly doesn't apply to our elderly gentleman. So I went ahead and I wrote a workup to further investigate, and here's the workup: CBC, CMP, BUN, creatinine. The pertinent workups also following imaging, we have carotid Doppler, fundoscopy, and I'm going to analyze the result of each result from this point on. So let's take a look at the result and let's analyze the result together. If we have a hunch on atheroembolism, that is mobilization of cholesterol, it's also called cholesterol emboli. There is a significant understanding in medicine that if there is elevated eosinophilia, and elevated eosinophilia is a positive finding for this case. Also, we have serum creatinine was 3, which signifies that he has acute kidney injury, could possibly be an embolization to the renal arteries. And so there are 2 important findings here: eosinophilia and a low serum C3 level. Low complementamania and elevated eosinophilia are a specific diagnostic findings for atheroembolism event. Now, is this atheroembolism necessarily a CNS, threatening CNS? Not at this point, because he had on Glasgow Coma scale, he was 15, and we will examine that more. Let's look at urinalysis. Urinalysis is within normal. The CMP came within normal. The MRI of the brain that I wrote, it was found to be within normal. Abdominal CT angiogram was inconclusive, within normal. Renal ultrasound found left renal enlargement, and SARS-CoV-19 RNA testing was also negative. So from the negative pertinent findings, we are more narrowing down the diagnosis towards atheroembolism. The ECG was found to have deep Q waves with T wave inversion, which fits in to the history of the patient, that he was admitted for percutaneous coronary intervention about a week ago, and he may have suffered congestive heart failure in time. There was a TM flow study done with right leg, 60% patent, and left arterial vessels for the left side with only 0.55, with 55% patent, which is not normal. It is subsufficient. And chest X-ray was within normal without mediastinal shift. Now, here's a CMP. Everything was within normal. There was a slight chloride deficiency. We can look past that. Now let's examine what Hollenhorst plaque is. Hollenhorst plaque is a specific finding in atheroembolism that rules in the diagnosis of atheroembolism. This plaque is often taken from the carotid artery, and it finds itself any branch that fits its size. Now, at this point, I would like to examine, we are going to take a look at the 3D model of the brain vasculature. And in this 3D model, I will explain how we have a Hollenhorst plaque forming. A formation of Hollenhorst plaque it can be best understood with this imagery. Now we have a 3D model of the brain. These are the vasculatures of the brain. I can move the model to my willing. This is the anterior cut sagittal of the brain. Here we have, I can bring the model forward. Here we have 21 is called internal carotid artery. Now we have 2 conditions, amaurosis fugax and amaurosis. Amaurosis fugax was the one that a plaque within the internal carotid artery was dislodged and the vision was slightly affected, but it was restored. And then there is another condition that is that causes blindness, and that is when the anterior retinal artery is blocked. So let's follow this diagram and find where we are. This is This is the internal carotid artery. Let's go to 22. This is the internal carotid artery. Calendula. This is pretty much, this is a still internal carotid artery. If I come to the right, I have ophthalmic artery. Now I would like for you to look at the bifurcation. The bifurcation has two characteristics. It is substantially narrow on this bifurcation, and it is also has a very sharp turn coming towards lacrimal artery and coming towards ophthalmic artery. Now, the Hollenhorst plaque, if Hollenhorst plaque was obstructing it at 24, it would have caused a complete vision loss, which would be amerosis. Amerosis in Greek means darkness. However, amerosis fugax means transient darkness. Now, the plaque that we observed in our patient moved through this branch, and it further moved through 25, which is lacrimal artery, at this bifurcation, not lacrimal artery, at this bifurcation, and passed to ciliary artery. So this is at the level of ciliary artery. If at the point of 25, the plaque formed, we would have complete vision loss, but we do not have complete vision loss. So what is Hollenhorst plaque? The Hollenhorst plaque moves to the end branches of ciliary artery. Now I'm going to show you, so one more time, let's take a look. Here is a complete, let's take a look at the big picture here. So here's a brain. Yes, so from the, so if the emboli move through a carotid, it will go through one bifurcation here that is very narrow and has a sharp turn. It could cause blindness, but our patient did not experience complete blindness. He had transient. So the emboli moved much further ahead. That would be distally. So let's go back and examine what is going on with our patient. So this way of finding helps us understand that this is not a CNS stroke. This is an atheroemboli that did not end in complete vision loss. So amerosis fugax is a carotid artery embolization that goes downstream and cause ischemia, transient darkness with revival of the vision less than 2 minutes. However, anterior ophthalmic artery vision loss would be a complete amerosis. Now, on physical examination, there is another important physical examination, and that is a negative relative pupillary defect. On physical examination, we found out that our patient was negative on relative pupillary defect. Now, I would like for us to examine what is negative pupillary defect. Negative pupillary defect is described this way. The light is shined, now is on the left eye. The right eye responds, the left eye responds. Now, one more time. The right eye responds, the left eye doesn't respond. Now the left eye doesn't respond again, and the right eye causes bilateral pupil constriction. So as a physician on the emergency room, you can go ahead and perform relative pupillary defect to simply differentiate if your patient truly has amerosis fugax or he actually has a amerosis, which is a complete obstruction of the central retinal artery. So one more time, just to recap. If it was positive for relative pupillary defect, it would be central retinal artery occlusion. If it was negative for pupillary defect and the vision was restored, it would be amerosis fugax. Now let's take a look in here just to recap. The elaborate perfusion map of the brain combined with the highly specialized homunculus of the brain's function has become the diagnostic guide based on the symptoms, and we have CT and MRI. So if you as a physician were asking me, why don't you consider the patient's complaint of vision loss to be a central retinal artery occlusion? Where on the fundoscopy of the patient, which we had, let's look at his fundoscopy one more time. This is his fundoscopy. On this fundoscopy, he's showing Hollenhorst, and he does not show signs and symptoms of cherry red macula or cherry spot with the central retinal artery occlusion and or the edematous and pallor of the central retinal vein. So there are plenty of syndromes that we all know, anterior cerebral artery, middle cerebral artery, and they all produce a specific CNS and nervous system symptoms based on the homunculus of the brain. However, with our patient, we focus on ophthalmic artery versus the amaurosis fugax syndrome, which we are honing down into amaurosis fugax more and more. Now, our patient also had a EKG done. On the EKG, this is the result of the EKG of the patient. We can see deep Q waves. So let me clarify. This is deep Q waves. That just tells me as a physician that my patient has experienced old myocardial infarctions, and there was some CHF. Well, for that reason, he was also was admitted for a stent placement and percutaneous coronary intervention. And that just confirms that our patient has had some congestive heart failure and he has suffered from that. So that is great. Now, from Glasgow Coma scale, how did I score my patient with Glasgow Coma scale of 15, even though he has atheroembolism? Well, from the general appearance description of the patient, we can score the patient. He's a 62-year-old elderly gentleman, reasonably groomed, communicate his symptoms, he's verbal, and that just helps me to score him 4 for eye opening, 5 for best verbal response, and 6 for best motor response. So this is one of the negative pertinent findings that tells me we are not having a CNS stroke at this moment. Now, let's go ahead and just to understand, a atheroembolism has certain requirements. For atheroembolism, generally, your patient should be greater than 50 years old. There is dermatological findings. There could be livido reticularis. We didn't have that. We have syndrome that we had on this patient. Acute kidney injury with creatinine up to 3, which was found on this patient, and amaurosis fugax on CNS. So having a sequelae of symptoms would help us hone down into understanding an atheroemboli that didn't produce major severe CNS symptoms. However, there is an atheroemboli. Let's recall having eosinophilia with reduced complementomania. Complement also helps to understand. The surgical history fits the protocol. There's percutaneous PCI, and the time of proximity should be within the past several months or the past procedures. Now, I have to, as a physician, be able to prove my diagnosis. So I would look into a history finding versus physical examination. From physical examination, to prove that there was atheroembolism, Glasgow Coma scale was 15. Therefore, this was not CNS related. However, he has Hollenhorst plaque, he has reduced serum C3 level, and he has 12% eosinophilia. These 3 findings are highly, highly sensitive and specific to understand that there is a plaque embolization. Now, let's look at the management drill of our patient if he had CNS symptoms.
Up in here. All right, Doc, we got a 77-year-old male who was at the pharmacy this morning getting his medication. Witness states about 7:35, she noticed him having left-sided weakness and facial droop and slurred speech. Blood glucose was 94.
Johnson, I'm Dr. Lee.
And onset was 7:35.
I'm going to be taking care of you, okay?
Thank you.
Thanks for the call.
I want you to
Appreciate
do
it.
a couple things for me. How many fingers do you see? 1. Good. How many? 2. Good. How about this arm? I'm going to hold it up there. Okay, ready? 1. Okay, good.
Ready to scan?
Yep.
Please notice the time elapsed.
We're going to do another picture of your brain, sir, okay?
One inclusion.
Right, and 1. Okay, why don't we call upstairs? I'll tell the endovascular suite that we have a go.
We're getting ready to do a procedure to actually remove the blood clot from the brain that's causing your symptoms, okay? Okay, I'm in the artery. All right, set up to do a run there. Do some angiography. Okay, there is a right MCA occlusion, just as we saw in the CTA, so we're going to proceed with pulling the clot out. Okay, let's do a run there, another angiographic run. Excellent. It looks like we've opened up the right middle cerebral artery. Let's look at the pre-images. So there's the occlusion. Looks like everything is open again. Great. All right, sir, I'm just going to unstrap you here for a second. I just want to see, can you raise your right arm off the table? Excellent. How about your left one? Hey, that's great. Can you smile really big for me? Excellent. That looks better than it did when you came in, okay? We're able to get the blood clot out, and you're already showing some signs of improvement. So I'm hopeful this means you'll have a good recovery.
Wonderful. As we can see, that our patient, within the 90 minutes, demonstrated signs of improvement, and that is incredible modality of treatment. But did our patient have CNS involvement? No, he did not have, because a simple, first of all, we did MRI, the MRI result was negative. And also simple clinical examination, physical examination can rule out the CNS involvement. Now, we discussed this one. Now, generally, the management of atheroembolism, there is no specific therapy for cholesterol emboli. To your surprise, you can admit and do supportive therapy, IV saline, aspirin, Plavix, matters that help the arterial obstruction. You can stabilize based on the Glasgow-Coma scale. Not everyone will come perfectly with Glasgow-Coma scale of 15, our patient. Therefore, we can move accordingly. There is reperfusion for ischemic stroke or revascularization for lower extremities for our patient, actually. But you can have the patient admitted, stay on it for one night, and examine the legs and see how the rubor, dolor, and calor of bilateral pedal edema, do they resolve on their own? And then we can move into an angiography for the lower extremity vascular. But you can take your time, and you can understand and study the patient a bit more methodical. It doesn't have to be very immediate, because brain was not involved, both from the MRI and both from clinical examination. Now, you can do supportive therapy and also to protect and prevent end organ damage. And we discussed coronary artery disease and preventions. Now, in general, lifestyle modifications, what is recommended to not to enter a state like that, to have atheroembolism or atherosclerosis. There are 6 food items that is understood and nutritionists recommend: cinnamon, red wine, salmon, avocado, and red pepper, and turmeric and garlic are well known for both anti-inflammatory, and also they have blood thinning effect, meaning anticoagulopathy effects, that if these 6 food items, or 7 with the avocado on the side, be included in your diet, is a great addition to your diet. Now, there are cuisines that very frequently take advantage of the spices. So we have Persians, Hindi, Mediterranean, Latin spicy cuisines that are well known for spices with anticoagulation benefits. And also, in the end, exercise reduces inflammation. And let me get back to this one. So these, the various cultures use the items that, for example, the turmeric or the garlic and red pepper are commonly used in the following cuisines, both for flavor and faint of heart, and also it is very, very healthy. So exercise reduces inflammation, and inflammation is known to be a nidus for atheromas. I recommend participating in aquatics or skiing, or also sports like Tai Chi, yoga, meditation, Kundalini, sports that are aerobic, help reduce inflammation and help alleviate conditions that prevent entering, causing atherosclerosis or atheroma or atheroembolism in the end. Also, preventing not smoking cigarette is a major importance. Thank you so much for your time. We really appreciate your participation in this presentation. Thank you, Dr. Stein.
Thank you, Dr. Navid.